Hello, and welcome to a special bonus episode of Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On this episode of the podcast, I'm talking to Dawn Adams, a midwife and a menopause advocate living with type 1 diabetes. We're talking about the impact that menopause can have on the management of diabetes, and this conversation is based on both her professional and personal experience. In this upcoming conversation, Dawn explains the overlapping symptoms of diabetes and menopause and the impact these can have on women, highlighting what GPs and other healthcare professionals need to consider when speaking with women with diabetes who are experiencing menopause symptoms. She also discusses how diabetes technology has helped her manage her own diabetes alongside the menopause, how to tackle stigma around both diabetes and the menopause, and what GPs can do to support patients and ensure they have a positive experience. This bonus episode of Talking General Practice has been supported by global healthcare company Abbott. Abbott's portfolio of life-changing technologies spans the spectrum of healthcare, with leading businesses and products in diagnostics, medical devices, nutritional and branded generic medicines. I'm delighted to be joined on the podcast now by Dawn Adams, who's a midwife and menopause advocate living with type 1 diabetes. Dawn regularly provides education sessions for healthcare professionals about issues related to living with diabetes. She's also published research investigating the use of wearable technologies during pregnancy, perimenopause and menopause. And she's currently working with diabetes advocacy groups, researchers and charities to identify and address the specific needs of those living with diabetes across the course of their lifespan. Thank you so much for coming on the podcast, Dawn.
Thank you very much for having me, Emma. It's great to be here.
So today we're going to be talking about the menopause and diabetes, in particularly about how the menopause affects women with diabetes and providing some practical advice for GPs and other healthcare professionals on how to best approach consultations with these patients. But before we get onto that, can you explain a bit more about how you became interested in this area and why you think it's important?
As someone living with type 1 diabetes for over 30 years now, as I was entering the menopause phase of my life, I found I was having to go back to my mum more regularly and get information because healthcare professionals just didn't seem to be as clued in to the impact of diabetes on menopause. I found for myself I was becoming much more insulin resistant, so I was needing increased doses of insulin. I was advised by my consultant team and by my GP to exercise more regularly, and working full-time as a midwife on a very busy delivery ward and having to run with beds. So I thought, well, where else am I going to fit in the exercise? I also have 4 children, so I was out with them and we were cycling, swimming, walking every weekend. Every time that I was off, we were out doing physical activity. And that didn't seem to be helping with the insulin sensitivity or the insulin resistance. And when I went to my GP and I asked about blood tests, because I'd heard you could get blood tests done when you were below the age of 45, she very kindly did them and the results came back normal. It's only in the last few years that I've discovered those can come back normal depending on where you are in your follicular cycles. But I was having so many other signs and symptoms, but it was the hormones that I was very focused on. Obviously, with midwifery, you're thinking in terms of hormones all the time. In terms of diabetes, you're always thinking hormones, hormones, hormones. I was so busy looking at the tree that I was totally missing what the forest looked like itself. So that was why I then started to look more into what research was available for women living with type 1 diabetes in particular around menopause. And there was virtually nothing. The only resource that I could find that was anyway useful had been published by Trend Diabetes. And at that stage, their information leaflet wasn't the fabulous 12-page booklet that it is now. It was an A4 page folded in 3. And the advice had been, check your blood glucose levels more often and adjust your insulin accordingly. Well, I was already wearing a Freestyle Libre glucose sensor at that point in time. And I thought, I can't do anything more to check my glucose levels. What am I meant to do? So I think that despair and that complete lack of information, that lack of any awareness was what led me to go into this area in a much bigger way. And I was facilitated in that by the advice and support of other women of my age living with type 1 diabetes who were experiencing the same things.
Was there anything during that whole experience? What was the thing you found particularly challenging or difficult?
Blood glucose management. And the fact that I was requiring additional insulin was there was a shame attached to that. There's such a shame and a stigma attached to numbers when it comes to diabetes. When you go to an appointment and you're getting your HbA1c and it's increased, when you're looking at your time in range and it's decreased, when you're looking at your total insulin intake and it's increased, and you think, gosh, I was getting 8 days out of an insulin pen only 3 years ago, and now I'm doing well to get 4 days out of an insulin pen. And you know that your diet hasn't changed, your weight hasn't changed, your activity levels haven't changed, nothing else has changed, but suddenly what you were doing isn't working at all. And I think it's that shame and that stigma and that embarrassment about having to say, I'm actually needing more insulin than normal. And when I'm taking it, it's not doing what it did 6 months ago, 3 years ago. That in itself is a massive challenge and a massive barrier, because we're also focused on trying to have flat lines on our glucose ratings, and we're trying to have a really good quality of life. And so much of that's stolen from you whenever your hormones decide to go AWOL. And looking back, the only other point in my life where I could have said, I had a similar experience would have been when I was pregnant. And initially, obviously in pregnancy, you require less insulin at the start of a pregnancy, and by the end, you're up to significantly more insulin. But I knew I wasn't pregnant, so it didn't seem to fit. And the only thing that I could think was, this has to be menopause related. This isn't just me. This is something different that I can't account for. But whenever I then was putting the pieces together with the very limited information that was available, there was a Cochrane review that I had read as well, and it had said about the higher insulin requirements. I thought, oh great, there's something. This is not just me. There is something out there. And then looking at symptoms of what was actually going on in my life, where I was losing confidence. I put the loss of confidence down to reduced time in range, increased HbA1c, increased insulin requirements. I was putting the tiredness and the fatigue down to being a full-time midwife with 4 sons who were pre-adolescent, early teens, playing rugby every weekend, just constantly on the go, having family members who were requiring additional time, additional care. And that sandwich generation thing was really starting to kick in. And I just thought, this is not just me. This is not just life. There is something else here. And unfortunately, the blood tests didn't validate what I was experiencing, but the symptoms were really lining up with what was going on in my life at that point in time. For me, that was such a driver to find out why. And I think the fact that in my own pregnancies, I'd also been involved in research projects because I attended a large hospital in Belfast where much pregnancy research had been carried out for the last 35 years. I was thinking, I need to find somebody who does research into this, trying to get that and trying to locate people who were interested in taking on women with diabetes for menopause research. It just wasn't happening 5 years ago.
Can you explain a little bit about the overlapping symptoms of diabetes and menopause, and then also what you've learned in the last 5 years about why there's this interaction between the two of them?
The big one for me was the hot flushes and confusing them with hypo symptoms. So in work, whenever I suddenly had a hot flush, sweat was running down my back, I just felt very flushed, very stressed. Checked glucose levels, went, no, that's not my glucose levels. This is something different. That was a big thing. And I say the having to change pajamas and bed linen during the night, thinking this is me back to those hypos that are the more disabling ones, but not having a hypo hangover the next morning, not having the pounding headache, not having the just feeling like moving through thick treacle the next morning wasn't there. I was very lucky that I was able to start attending conferences focused around diabetes. And as I was going along to those, I was seeing more information coming through about aging with diabetes. But menopause, very carefully left out of those, again, because such an under-researched area. And whenever I was at international conferences, I was hearing about the impact of type 1 on brain health, brain function. And I started to think that I was actually going down the route of an early dementia because I was becoming so forgetful. And I thought, this is my diabetes doing this to me. Not realising that that in itself is a menopause symptom where you walk into a room, you can't remember why you're there. You get into the car to do something, you think, why am I in the car? Where is it that I'm going to? And again, thinking, is it because I've had type 1 for such a long time? Is it because I'm hypoglycemic? Is it because I have my sensor maybe isn't reading accurately, but when I was checking sensor readings with blood glucose readings, they were matching up. There was no disparity between those. The sleep as well was a big thing. We know that people with diabetes don't have particularly wonderful sleep because of high blood glucose, because of low blood glucose, because of that physiological interaction of diabetes itself. Again, there were so many things that were just paralleling. Dry skin, again, could be linked to diabetes. Urinary tract infections can be linked to diabetes. And I was looking at the overlap with the confusion, the irritability, the loss of confidence, dry skin, all of those things. I'm thinking, no, this is diabetes. This is diabetes. But the more that I looked at my HbA1c, which because I was now starting to give the extra insulin to keep me in range more frequently, and because I was starting to drink more water, actually because I was sweating so much, I was midwife head on. I was thinking in terms of, oh, I'm becoming dehydrated. That's why I'm having these high blood glucose levels. And realizing that those things were lining up beautifully in terms of my clinical results, but weren't lining up beautifully with what was going on in the rest of my life. And as I mentioned previously, having peers who were at similar points in their lives, we started to have conversations online. And then we were so motivated by the online conversations that we were having amongst two or three of us. We started to have regular Zoom meetings because by that stage we'd hit COVID. For each of us, it was really empowering because when we lined up what we were experiencing, the fact that it wasn't just one of us, it wasn't just two of us, it was half a dozen and more of us, that it gave each of us actually the confidence to contact our GP to ask about hormone replacement therapy. So that was almost like a light bulb moment. But we were putting it all down to, it's just another diabetes thing and it's my fault and I've caused this. And there's so much of that shame and that guilt that you have done something to yourself as a result of your diabetes mismanagement, having the validation from others who had different life circumstances, who maybe weren't as overwhelmed by family responsibilities or career responsibilities.
When you got the HRT, did that help with everything? Made you realise that it was the menopause and not your diabetes that was the problem?
Yes. By 4 weeks in to starting the estrogen patches and the progesterone tablets, I felt like a whole new woman. I felt like I had felt 5 years previously. I had reduced the numbers of hot flushes. I had significantly reduced the lack of confidence that was coming back round. And it made sense. Obviously, when you've type 1, when you've type 2 as well, you aren't making insulin or using insulin in the same way as people who don't have those conditions because you're hormone deficient on one level for one reason or another. And replacing the progesterone and the estrogen just gave me back my life in a way that when I started an insulin in 1993, I was suddenly feeling like, hey, I'm back in the room again. This is great. I have a future ahead of me. And I felt able to do things that I hadn't felt able to do before.
You talked there about the way it impacted on your confidence. From your experience, all of the symptoms that come with going through the menopause when you've got type 1 diabetes, what sort of impact can they have on people's lives? Is it that confidence that's the main issue?
The confidence and the increased shame and the increased stigma are big things. When you feel confident, you can tackle people throwing comments at you about, oh, you obviously caused your diabetes yourself, or maybe if you had tried to run more whenever you were younger, maybe if you had eaten this whenever you were younger, maybe if you had done that. You get all this weird, wonderful advice. You always feel like a burden for having type 1 in particular. I know people with type 2 would say they feel like a burden as well. And you always feel like it is actually the only medical condition that you're constantly managing on your own, that you're responsible for 24 hours a day, 7 days a week, 365 days a year. But whenever you have something else which is causing your diabetes to misbehave, in spite of all the things that you try to do to keep this very feral animal that diabetes is under control as much as you can, or in the room with you, the shame and the stigma that go with that just add an additional level of burden. And it was interesting because Abbott had done a study with people living with diabetes, and they had identified that approximately 1 in 4 people with diabetes have experienced stigma and shame, which impacts our ability to take on the things that we should be doing, could be doing, need to do to self-manage effectively and well. And we also know that the shame and the stigma can impact your ability to leave the house. It affects the way that you look at your insulin for people with type 2. It affects the way they look at their metformin. That in itself causes so many additional problems, so many additional difficulties, because by not adapting to what your body requirements are, you potentially impair your long-term health outcomes. And the one thing that I think all of us want to do, if we're doing anything at all, like even checking blood glucose once a day or once a week, that's still having a bigger impact than not ever taking a smaller amount of insulin because you're so ashamed that you need the larger amounts of insulin, skipping meals. Those things have such a combined negative effect. And again, we know that there's a higher rate of depression in people with diabetes. But we also know that women experiencing menopause have more risk of depressive symptoms. And that quite often that reduction in progesterone, estrogen, and testosterone can have an impact mentally as well as physically.
Once you started managing the menopause, did you find that the amount of insulin you needed to take, did that start to go down again?
It did, yes. I wasn't as insulin resistant as I had been.
And how has your professional background helped you in your understanding of the menopause and diabetes and how they interact with each other?
I think because of my career, I have an interest in research. Obviously, so many things are changing in the world of women's health on a regular basis. And as midwives, we're constantly responding to inquiries, we're constantly responding to reports globally, nationally, and changes in the way that pregnancy can be optimized. So I started to take some of that interest and shift it across into what the wider field of female health was looking like and why I was experiencing different symptoms, while my friends were experiencing different symptoms. You're not just reading a research paper and going, oh yeah, that validates what I think. You're having to think, well, does that actually say, what are the researchers' biases here? What is the prime focus? Who sponsored this research study? Who looked at this? Why would this be a thing? Then finding research which you're hoping is going to contradict the paper that you've just read, because that's not really very difficult in the research world. But that was what led me down a route. And then I also decided, again, probably spurred on by menopausal changes in my life, I decided to apply for a PhD. So that also opened up a greater access to an awareness of information and research.
And you've been focused on diabetes and the menopause in that. Is that what you've been looking at in particular?
Unfortunately, menopause didn't come into that. Menopause kind of sat alongside it, though, because it was diabetes, pregnancy, and wearable technology. But I thought, well, if we can apply this to pregnancy with wearable technology, this should be transferable to other hormonal phases in life and the use of wearable technology.
Well, I'm going to come on to ask you about some wearable technology in a minute. But first of all, just to bring in general practice here. So GPs are often the first port of call in both a patient's diabetes journey and also when they start experiencing the menopause. How important are those interactions with patients, do you think, and how can they shape future interactions with other healthcare professionals? Is there anything GPs can do at this point to set women up for better outcomes?
I think, first of all, providing reassurance that, number one, it is unlikely to be depression unless someone has factors going on in their life which would strongly suggest that there's a level of depression going on. I think being open to the awareness that insulin levels or metformin dosages aren't working the magic that they worked a few years previously, and being aware that even making an appointment to go through the door to talk about something like hormones, to talk about something like glucose levels, takes a huge amount of courage, because you have that concern, that worry, that fear that you're going to be judged or deemed to be not managing your condition as you should be. We know that approximately 60% of women aren't comfortable talking to their GPs about their health. They'll come in and they'll talk about maybe a rash that they've developed, and it will only be after something has been prescribed for the rash that they'll say, oh, just while I'm here before I go. And maybe allowing for that to be part of the conversation would be very helpful. And again, we know that GPs are time tight, like everything in the NHS at the minute, but trying to have as supportive a conversation as possible. Maybe asking the questions like, well, do you think this could be a sign or a symptom of menopause? Have you considered that maybe what you're feeling at the minute might be a result of this phase of life that you're in, without making it, this is definitely what it is.
You mentioned wearable technologies, and obviously there's lots of new technology that's kind of come on stream around diabetes. How has that technology helped you manage your diabetes alongside the menopause?
For me, it has had a massive impact. As I say, I've been on an insulin pump for just over 12 years now. So whenever I was seeing my blood glucose levels rising, in spite of the fact that I was trying to adapt my background rates, my basal rates of insulin, and I was changing my carb ratios, the wearable technology actually let me see how well I was doing that and how successfully the changes that I was making on my insulin pump were working. They weren't. It's the bottom line, because I had that fear of increasing my basal rates. I had that fear of increasing the amount of insulin covered for carb doses as well. But once I was willing to accept the fact that this was a phase of life that I was in and I was going to need this additional insulin to get me through it, once I shifted my mindset to think about, okay, my 4 pregnancies and what third trimester looked like, I went, well, I'm nowhere near those levels of insulin, but I'm definitely not what I was ever pre-pregnant. Having the technology helped me to make the tweaks that I needed, where I needed, and as I needed. So I use an insulin pump, and I also use a Freestyle Libre 2 glucose sensor. So that's a wearable sensor which has a microneedle. Measures the glucose in my interstitial fluid, and I wear it for 14 days. It provides me with information about my time in range. It provides me with graphs to show how my glucose levels have been over the course of a 24-hour period. And when I log into my computer or another app associated with the Libre 2 sensor, I'm able to see what my daily glucose levels are looking like overall. It helps to give me a predicted HbA1c, and it helps to give me information about how well I'm doing with pre-bolusing my insulin, how well I'm doing with activity levels, and what the impact of more active days, what impact that's having on my glucose. And with the rollout of the Libre 2, that then provided alarms for me. And I know that other glucose sensors also have the alarms, but it was the alarms that really gave me much more confidence, even in the workplace, even when doing my research or doing presentations, because I knew, okay, my trend arrow is going this way. Now would be a really good time to have something to eat. Or my trend arrow is going that way. Okay, I'll take this amount of insulin. We'll see what happens. And being in range makes a phenomenal difference, even to your cognitive ability and even to your professional attitude, your way of dealing with people. Personally, I know whenever I drop below 4, I become a little bit confused when anybody's trying to talk to me. Whenever I go above 12, I find it difficult to continue with a task simply and purely because there's that sluggishness. So having the sensor and having those alarms set at a place where I could take action before the blood glucose changes were starting to impact my cognition was so very important, so very valid for me as well. That was a massive thing.
One of the things you've talked about quite a lot through this conversation is stigma. And you've talked about stigma around diabetes, but also there's obviously a lot of women feel stigma around the menopause as well. And I think you've described it as you're basically facing double stigma when you've got both of these things going on in tandem. Can you explain a bit about what you mean about that?
It's the comments that people make. So certainly with menopause, it's the fact, oh, you're past your prime now. It's all downhill from here. You're faced with a lot of comments that you're not young anymore. Even in the workplace, there's the stigma around being older. How could you understand a young person's health issues? How can you understand what it's like for young people now when you didn't have social media at this age? I think even certainly within the workplace, not menstruating in a maternity ward it comes with a different level of stigma and shame because, oh, you're well past that. You don't remember what it was like anymore. That's from female colleagues, that's from male colleagues. And with diabetes, there's obviously the stigma that goes alongside that. And as I've said, it's the shame that you have diabetes, that you've done something which has caused this. You've eaten the wrong food, that you haven't exercised enough. And I think for young people with type 2 in particular coming into the system now, they're facing that in a much more acute way than people in their 60s and their 70s being diagnosed with type 2. It's not an easy diagnosis for anyone to receive, but a large part of the difficulty with being told that you have diabetes, the difficulty with being told that you're in perimenopause, that you're then menopausal, postmenopausal, is there's so little that you can actually do to control that. The jokes that are quite often made about both conditions aren't particularly funny whenever you're the person with either or both of those conditions. They tend to sting quite hard. I would generally be quite a resilient person, but there have been times whenever I have been severely scorched by comments that have been made to me. As someone who's fairly thick-skinned, and certainly as a mother of boys, you have to be quite thick-skinned, but there have been times where I've been completely caught off guard by what someone has said, and they've meant it in a funny way, and it has been anything but hilarious.
Taking all of this into consideration, what we've been talking about today, how do you think GPs can support women so they have a positive diabetes and menopause journey and they continue to feel supportive throughout that journey?
Open conversations, big thing. Asking about family. Again, I'm very conscious of the fact that the time is so tight when you're in that room, but maybe unpicking some of the other things that are going on around someone else's life. And the signposting towards the trend diabetes information leaflets, signposting towards research, which has been carried out. Abbott have their research that they've completed, and there are now other research projects which are in place, which are looking for people to join them, to come on board and share their experiences. And I know that for a number of women, that seems like another time commitment. And it seems like something which isn't going to benefit them. And to be honest, probably isn't going to benefit them directly. But I think if it can be couched in such a way that they feel empowered and that they're signposted, directed to things like menopause cafes, menopause peer support groups. Again, for the mental health side of it, that's so important because having a community of any sort, we know from all fields of medicine that sharing experiences with people who have experienced something similar can help to reduce some of the trauma, can help to reduce some of the fear, some of the anxiety. And seeing other people who have had the same thing going through and coming out the other side well is really important. Even things like if someone comes in and requests HRT, There are more women who are starting to use things like the Balance app to identify what symptoms might be, and validating that would be a big step, I think, for anyone coming into the room, because, as I've said, there is a discomfort about coming in and talking about women's health, women's issues. It's kind of like a whispered thing still, not so much as whenever I would have been in my teens and my 20s and women would have just nodded at each other. There is more of a conversation, thankfully, going on. And I think for GPs to facilitate and encourage those conversations would be a positive step forward.
Well, I think that's a really good place to leave it. Thank you so much for your time, Dawn. It's been really great to talk to you today. Thank you.
Thank you for having me. It's been fabulous.
Well, that's it for this bonus episode of Talking General Practice. Thanks for listening, and thank you so much to Dawn for taking the time to talk with me. You can find links to more information about Abbott and the company's Freestyle Libre product in the description for this episode, as well as links to some of the resources that Dawn mentioned during this conversation. I'll be back with our usual podcast on Friday, so please do join me then.